Today's topic is rectal cancers. Rectal cancer is a malignant tumor arising from the rectum, which is the terminal portion of the large intestine. Located above the anal canal, it is one of the most common colorectal malignancies and contributes significantly to cancer-related mobility and mortality worldwide. This is a rectum over here. We can see over the enlarged images over here. So the tumor arises mainly in this region. Rectal cancer is a malignant neoplasm originating from epithelial lining of the rectum, characterized by uncontrolled proliferation of abnormal cells with the ability to invade surrounding tissue and metastasize to the lymph nodes and distant organs. So the epidemiology of rectal cancer, it is most commonly seen in age group of above 50 years, predominantly mostly seen in males and lesser in females, but nowadays young population also being affected by rectal cancer. In India, mostly colorectal malignancies are becoming increasingly common because of westernized dietary habits, reduced fiber intake, increased consumption of processed foods, sedentary lifestyle, and obesity. The etiology and risk factors. Diet over here plays a major role in colorectal cancers. Diets rich in red meat, processed food, animal fat, refined carbohydrate increase the cancer risk, whereas high fiber diet are protective. Smoking, alcohol consumption also contribute to DNA changes, which may lead to rectal cancers. Obesity, and sedentary lifestyle are strongly associated with colorectal malignancies due to metabolic and inflammatory changes. Chronic inflammatory bowel disease such as ulcerative colitis and Crohn's disease increase the risk of dysplasia and malignant transformation of the cells. Now coming to the pathophysiology. The pathophysiology of rectal cancer involves progressive transformation of normal rectal mucosa cells into malignant cells through sequence of genetic and cellular alterations. Most rectal cancers develop through the adenoma/carcinoma sequence. In this process, the normal mucosal epithelium undergoes dysplastic changes, resulting in formation of adenomatous polyp, which gradually becomes malignant. So what happens basically over here? So the constant stress on the mucosal lining of the intestine causes DNA changes. Constant stress and repair on the DNA lining of the intestine causes DNA changes, and thus the cells become malignant cells, and thus a formation of adenomatous polyp occur, which gradually becomes malignant. Genetic mutation involve tumor suppressor genes and oncology genes disrupt the normal cell growth regulation, apoptosis, and DNA repair mechanism. Important molecular abnormalities include mutation in APC gene, KRAS gene, P53 tumor suppressor gene. This mutation is uncontrolled, and cellular proliferation and progressive dysplasia occurs. Submucosa muscularis propria, perirectal tissues. As tumor growth progresses, the rectal lumen narrows, causing altered bowel habits and bowel obstruction. Tumor invasion into nearby pelvic structures may produce pelvic pain, urinary symptoms, sexual dysfunction. As the rectum has an extensive lymphatic network, it allows earlier spread to regional lymph nodes. Hematogenous spread commonly occurs to the liver, lungs, bones, and advanced disease may produce weight loss, cachexia, fatigue, malnutrition, and weakness. So here are some of the stages in brief. You can go through this. Then the clinical manifestations. Clinical manifestations mostly depend on the tumor size, location, and the stage. Early rectal cancer may produce mild or intermittent symptoms that are often ignored. Rectal bleeding is one of the most common manifestations over here. Blood may be mixed with stool or appear separately. Altered bowel habits commonly occur due to narrowing of the rectal lumen and irritation of the bowel wall. Patients may experience constipation, diarrhea, pencil-thin stool, incomplete evacuation, tenesmus, which is a constant urge to defecate with incomplete relief, is characteristics of rectal involvement. As the tumor enlarges, patient may develop abdominal pain, pelvic discomfort, fatigue, weight loss, anemia, and advanced Most tumors may obstruct the bowel, causing severe constipation and abdominal distension and vomiting. Now, the diagnostic evaluations of rectal cancer involves clinical examination, that is endoscopic procedures, imaging studies, histopathological confirmation. DRE, that is digital rectal examination, is important initial assessment because many rectal tumors can be palpated manually. Colonoscopy allows direct visualization of tumor, and biopsy collection for histopathological confirmation. Biopsy remains the gold standard of diagnosis, whereas MRI of the pelvis is especially important because it accurately evaluates the tumor depth, mesorectal involvement, lymph node spread, and the CT scan assesses for distant mets. PET scans also help identify distant mets and reoccurrence of the disease. Some diagnostic tests such as occult stool blood test and CBC can also be used, in which occult stool blood test helps in detecting blood in the stool, and CBC helps to rule out anemia. Then comes the TNM staging, wherein the T stands for tumor size, N stands for regional node involvement, and M for distant metastasis. In this we see understanding the rectal wall anatomy is essential for TNM staging. The rectal wall consists of mucosa, the innermost layer, the submucosa, muscularis propria, subserosa, perirectal tissue, and serosa, that is the outermost layer of the rectum. Deeper invasion is associated with worse prognosis. We need to remember this. In primary tumor, T category describes the extent of tumor invasion into the rectal wall and its surrounding. Over here, TIS is carcinoma is in situ confined to the mucosa. T1, tumor invades the submucosa, the second innermost layer. T2, the tumor invades the muscularis propria. T3, the tumor extends into the perirectal tissue, that is, it has invaded to the mucosa, submucosa, muscularis propria, and now it has reached the perirectal tissues. T4A, tumor penetrates the visceral peritoneum, and T4B, the tumor invades adjacent organs such as bladder or prostate, which is nearby, which is in surrounding of the rectum. Then coming to the N classification, N stands for regional lymph node involvement, wherein N0 is a regional lymph node. There is no regional lymph node metastasis. N1A, metastasis of one regional lymph node. N1B, metastasis of 2 to 3 regional lymph nodes. N1C, tumor deposits within nodal metastasis. N2A, metastasis of 4 to 6 lymph nodes. N2B, metastasis of 7 or more lymph nodes. The M stands for distant mets. M category indicates whether cancer has spread to distant organs, wherein M0 there is no distant mets. M1A, metastasis to one distant organ. M1B, metastasis to multiple organs. M1C, peritoneal metastasis is present. Then coming to the medical management, the first line of treatment is chemotherapy in medical management. The chemotherapy is the use of cytotoxic drugs to destroy the rapidly dividing malignant cell. It is an important component of rectal treatment, especially in locally advanced disease, lymph node positive disease, metastatic disease, and recurrence of disease. Chemotherapy can be administered in various ways, that is, before surgery, which is known as neoadjuvant chemotherapy, after surgery, adjuvant chemotherapy, along with adjuvant chemotherapy is after surgery, along with the radiotherapy, or as a palliative care treatment. The neoadjuvant chemotherapy is given before to surgery to reduce the tumor size, improve the surgical resectability, and preserve the function of the sphincter. Whereas the adjuvant chemotherapy is administered after the surgery to destroy the residual malignant cells, reduce the recurrence risk, and improve long-term survival. When chemotherapy is given, certain side effects are also seen in this, but before this we'll just name few drugs which are used in chemotherapy to treat rectal cancer. The first one is 5-fluorouracil. It inhibits the DNA synthesis of the cell. Then oxyplatin. It prevents the cross-linking shrinking of DNA and causes apoptosis. Leucovorin enhances the effectiveness of 5-fluorouracil. So when chemotherapy is given, certain side effects are expected, such as side effects of GI system, which causes nausea, vomiting, diarrhea, mucositis, hematological side effects such as anemia, leukopenia, thrombocytopenia. Side effects on hair and skin may cause alopecia and skin changes. Nervous system, peripheral neuropathy may be caused, and generally overall fatigue and weakness may be seen. Even bone marrow suppression is one of the most important complications. It may cause neutropenia, that is which can cause increased infection risk, anemia, fatigue, which may cause fatigue and weakness, thrombocytopenia, which may cause bleeding. Then coming to the radiation therapy. Radiation therapy uses high energy radiation to destroy malignant cell and reduce the tumor growth. It is especially important in rectal cancers because the rectum is located within the pelvis. The local recurrence risk is high, and tumor shrinkage improves the surgical outcome. Like same as chemotherapy, radiotherapy can be given before surgery or after the surgery. Before surgery, it is known as neoadjuvant therapy, which is also given to shrink the tumor size and improve the operability and reduce local recurrence. And adjuvant therapy, it is given after the surgery when the surgical margins are positive, the residual disease is suspected, the lymph node involvement exists. Then there are also side effects of radiation therapy, such as side effects on the GI system, which may cause diarrhea, abdominal cramps, proctitis. Side effects on genitourinary system causing dysuria, increased urinary frequency, side effects on skin erythema and irritation, and generalized fatigue may be a side effect of radiation therapy. Then coming to targeted therapy. Targeted therapy acts specifically against molecular pathways involved in tumor growth and spread. Unlike conventional chemotherapy, targeted therapy selectively attacks cancer cells while minimizing the damage to normal tissues. Targeted therapy is mainly used in advanced disease, metastatic rectal cancers, or recurrent cancer. It uses anti-vascular endothelial growth factors known as the anti-VEGF therapy. Bevacizumab inhibits a common drug uses bevacizumab. It inhibits the vascular endothelial growth factors, reducing blood supply to the tumor. This slows down the tumor growth, prevents angiogenesis and metastasis. The side effects of targeted therapy may cause hypertension, skin rash, delayed bleeding, diarrhea, and fatigue. Patient may require close monitoring during this treatment. Then coming to the nutritional management. Nutritional support is essential because patients commonly develop anorexia, weight loss, diarrhea, malnutrition, and weakness. The goal of nutritional management is to maintain body weight, improve treatment tolerance, promote healing, reduce complication. Dietary recommendations include high protein diet, adequate calorie intake, small frequent meals, adequate hydration. Patients with diarrhea should avoid spicy food, high fat food, and irritating food. Then coming to symptomatic management. Symptomatic management mainly focuses on the symptom control, such as management of pain, which include use of opioids, non-opioid analgesic, and adjuvant medicine. Management of rectal bleeding which will require blood transfusion, iron supplements, hemostatics therapy, radiotherapy, endoscopic interventions, and timely management of diarrhea with the use of anti-diarrheal medications, hydration therapy, electrolyte replacement, and dietary modification. And then management of bowel obstruction. Management may include nasogastric decompression, colostomy formation, stenting, surgical diversion, psychological support. Patients often require assistance coping with fear of colostomy, bowel movements regularly, assess stool consistency and frequency, encourage adequate fluid intake, promote high fiber if appropriate, administer stool softeners or laxative as prescribed. Patient may experience constipation, diarrhea, incomplete evacuation, urgency or incontinence. Post-operative bowel dysfunction should be monitored carefully. The nurse should also observe for signs of bowel obstruction such as severe constipation, vomiting, abdominal distension, absence of bowel sounds. Then, colostomy care. Patients with rectal cancer require temporary or permanent colostomy formation following surgery. Colostomy care is one of the most important nursing responsibilities. The nurse should assess for color, size, and output, maintain proper application fitting, prevent leakage, protect peristromal skin, empty stomach pouch regularly, teach stomach care techniques to the patient. A healthy stomach should appear pink or red, moist, and slightly protruding. The bluish black discoloration may indicate ischemia and require immediate attention. Patients should gradually be encouraged to participate in self-care to promote independence and confidence. Peristromal skin care. Peristromal skin irritation is a common complication caused by leakage of fecal material. The nurse should keep the skin clean and dry, use skin barrier products, change application properly, assess for redness or ulceration, prevent prolonged moisture exposure. Proper skincare prevents excoriation, infection, pain and application leakage. The nutritional management is mainly to prevent. The nutritional support is essential because many patients may experience weight loss, anorexia, fatigue, diarrhea and poor appetite. The nurse should monitor weight, record dietary intake, encourage high protein calorie diet, promote adequate hydration, provide small frequent meals. Patients with diarrhea may require dietary modification and electrolyte replacement after the surgery. Gradual progression from liquid to soft diet is usually necessary. Dietitian consultation helps provide individualized nutritional support. Under pain management, pain mainly results from tumor invasion, surgical procedures, radiation therapy, bowel obstruction. Patient pain assessment should include intensity of the pain, location of pain, duration of the pain, aggravating factors towards the pain, and relieving factors towards the pain. Pain management include opioid analgesics, non-opioid medications, relaxation techniques, comfortable positioning, emotional support. Then there is post-operative nursing care. Patients undergoing colorectal surgery require intensive post-operative nursing care. Immediate post-operative nurse priorities include airway maintenance, monitoring vital signs, fluid electrolyte balance, pain management, prevention of infection, monitoring bowel function. The nurse should monitor for hemorrhage, anatomical leak, paralytic ileus, wound infection, and urinary retention. Early ambulation is encouraged to prevent deep vein thrombosis, pulmonary complication, and paralytic ileus. Then fluid electrolyte management. Patient may develop fluid imbalance due to diarrhea, vomiting, colostomy losses, surgical drainage. The nurse should monitor intake output, assess hydration, monitor electrolyte levels, administer IV fluids as prescribed. Signs of dehydration include dry mouth, hypotension, weakness, reduced urine output. Then the patient may also require psychological support. Then radiation side effect management, such as the radiation may cause diarrhea, radiation proctitis, fatigue, skin irritation, urinary symptoms. The nurse should monitor for bowel function, encourage hydration, provide skin care, administer medication as prescribed, encourage rest period. Sexual counseling may be necessary for the patient. Then patient education on colostomy care, dietary modification, hydration, medication adherence, wound care, signs of complication and follow-up should be explained to the patient. Then coming to the nursing care plan. The first care plan is acute pain related to tumor invasion and surgical intervention secondary to rectal cancers. And here is a temporary nursing care plan over here. You can go through it. Then the second nursing Second diagnosis is constipation related to bowel obstruction and altered bowel function secondary to rectal cancer. This is also a sample Kaplan. Then one more sample Kaplan over here is risk of impaired skin integrity related to fecal leakage around the stoma site. Go through this also. Then the fourth Kaplan, disturbed body image related to colostomy formation and altered physical appearance